No, I think this is a great topic that actually has a lot of controversy. I think you'll get varying opinions depending on what podiatrist you speak to, whether or not they think the show part is a good amputation or not. Would you mind speaking, Dr. Resendez, about the importance of the PT artery and dissecting that out and ensuring that for the success, full healing of your flap and show parts?
Absolutely. Yep. There are a lot of structures, obviously, that are extremely important in that procedure, in all procedures, including the show parts amputation. So obviously, we all know when you're looking at that plantar flap, whether you're doing a TMA or a show parts, that plantar flap, the vascular status of that plantar flap is so important because that's going to keep your flap alive. So being very careful with your vasculature, as well as keeping all of that intact. And as you do the same with a transmetatarsal amputation and really getting that connective tissue and that plantar flap off of the bone and doing that stripping, if you will, trying to preserve the entire flap all together, okay, as one envelope of tissue, getting that off your bone, preserving the PT artery. Also, when you're doing your dorsal cut and preparing for your amputation on the dorsal aspect of the foot, you don't want to completely sever your anterior tibial tendon because you're going to need the length of your anterior tibial tendon to be tacked to the dorsal aspect of the talus. And I've read a lot of literature that says the lateral aspect of the talus. I usually go to the dorsal neck and a little bit lateral of the talus when I anchor in my anterior tibial tendon, and I always do a gastroc recession. But the key pearls that I use for this procedure that I've learned along the way are to break your surgery. If you are doing a show parts, obviously you wouldn't do a show parts in someone that can have a transmetatarsal amputation, okay? This is for those candidates, those patients that the whole forefoot is destroyed from infection. And basically you have a plantar flap that's viable from the middle of the arch and to the calcaneus. So in order to not do an above ankle amputation, this show parts can be a lifesaver. Really, it can be a lifesaver considering that after all major amputations, 56% of the patients are no longer with us after 5 years that have had a major amputation. So break the surgery up into two parts. There's the dirty part, obviously, in the beginning of the surgery, which is when you are getting the infection off, you're dissecting all of your vital structures. Once the whole dirty part of the case is removed and we've got our bone cultures, our tissue cultures, we've resected the bone, I actually re-scrub, I re-prep, we re-drape. My scrub tech re-scrubs, and we start the whole brand new part of the case, so to speak, so that when we're anchoring that anterior tibial tendon to the talus, and when we're doing our gastroc recession and when we're closing our flap, we are as careful as possible to now start doing that under a clean environment. So I actually re-prep, re-drape, re-scrub. I re-prep the patient, everything all over again from the second half of the surgery, and always have a second set of clean instruments for that second half of the case. And this can save your patient in a large way, as far as when the patient at night, they don't have to put on a prosthetic. They don't have to remember that they just had an amputation, so they need to put on a prosthetic just to go to the bathroom, just to go fix a quick meal. Once they're healed, which is usually, obviously, if the patient has PVD, it's longer. If the patient does not have PVD, usually these patients heal up in 3 weeks, and they can get fitted for a prosthetic, and they have same leg length equality. They don't lose that contact point. There are a lot of benefits to this procedure, and obviously it's not considered a major amputation.
I think that was a great
Oh,
presentation.
that's great. Thank you so much. Sorry?
One question I had for you was, what's your personal experience with the AT tendon and tacking that down? Are you worried? I know we do our best at cleaning everything, but are you worried about infection or bacteria being left behind in that AT tendon and causing another bone infection of what you left?
That's a great question. And I'm always concerned about that, always, 100% of the time. And I can honestly tell you, knock on wood, I have never had an infection of osteo transferred from the anterior tibial tendon. And I will say that during the dirty part, when I resect everything off, after everything's been resected, I pulse lavage with bacitracin irrigation, and I use a good amount of saline. So I'm always using antibiotic in my irrigation. And then once we put a dressing on the patient after the dirty part, put a dressing on the patient, and then actually we then take that dressing off, re-scrub, re-prep, do all of that again. And after we re-prep and start the second half of the surgery, obviously I usually just use bone anchors. I don't use a tenodesis set. I just use a quick bone anchor. I know we shouldn't be using the actual brand names, but you know, my tech is really easy because it's just quick and it just anchors the tendon. And it's usually done a good enough job. I've never had one pull out, nor have I had osteomyelitis transferred into the neck or head of the talus.
Perfect. Thank you.
Mm-hmm.
Wonderful. No, this has been such an exciting, session. And, one of the things that I just want to mention is that we actually had a really great and you come to the event, it's a lot more of what you just saw in this very short session we had together. And there's, you get to meet and talk and discuss with other vascular surgeons or interventionalists and vascular medicine specialists. It's really a great educational event. And I think that right now, limb salvage and podiatry, I think that's actually really the glamorous part of podiatry, in my opinion, because that's the part of podiatry where we're saving lives. And it's so important for us to be educated and be able to show up and be that advocate for our patient. So I really hope that you enjoyed today and that you come back next year, and we'll see you then. Thank you to everyone who participated, and we really appreciate you.
Thank you for the invitation. That was wonderful.
Thank you so much. And thank you, Rose, for despite technical challenges, despite not having electricity, you did such a fantastic job. And all the panelists, and I'm getting texts from some of my local podiatry students. They love your session. And so thank you so much again. You taught us a lot, and the panel and everyone. I hope everybody enjoyed it. We have another session starting at 5 p.m. with Dr. Paul Saraja. They will be discussing transcatheter intervention for adult congenital heart disease. So for those that are interested, we're going from the feet to the heart again. That's the beauty of our conference. We cover everything. So thank you again, and have a wonderful weekend, everyone.